Hi, my name is Peter Bow from the University of Manchester, and in the next 12 minutes I'm going to try and answer the question, is health research undertaken where the burden of disease is greatest? So Chris Whitty and Louise Wood wrote to the NIHR several months ago talking about progress, and one of the things they raised was the issue about where research was being done. And they said at the more applied, clinical and public health end of the spectrum, there's a strong scientific need for research to be conducted with and in the populations most affected. So why is this important? We've known for many years that research done in healthier populations may not generalise to those in less advantageous conditions. Often research that we're doing relates to interventions, and we know that the effects of interventions, their implementation and their effectiveness may vary with context. Recruitment's the biggest problem in terms of study delivery, and all other things being equal, recruiting in areas high prevalence could be more efficient because there's just more people who would be potentially eligible. And there's a moral issue here. There's increasing evidence that taking part in research is a positive experience and leads to improvements in organisational performance. And as publicly funded research, there's a really good argument that it should be accessible to everyone, no matter where they live. So when this was raised, one of the issues that we wanted to look at was, well, what's the evidence for this suggestion about where research is being done? And so with this research, we went out to try and answer three questions. First, is recruitment aligned with disease prevalence in England? How does alignment vary across clinical specialties? And is alignment getting better or worse over time? So we use two types of data to look at the burden of disease. We use the quality and outcomes framework data on long-term conditions, and we use three sorts of data looking at all long-term conditions combined, and then we split off mental health and diabetes to allow us to at least explore the effects of different specialties on the way research is aligned with a burden. To complement that, we then looked at CRN recruitment data. Now this is structured in two ways. There are 15 LCRNs, local clinical research networks in England, and 195 CCGs, and we looked at both of these in our analyses. Now the thing to remember here, the important issue, is that CRN recruitment data that is collected on recruitment location, not on where people live, but where they were recruited. And this has important implications. So when we looked at the LCRN, it's highly likely that people are matched to the correct LCRN in terms of where they were recruited and where they live. So there's an accuracy to the LCRN data, but obviously it's low granularity because there's only 15 LCRNs across the entirety of England, and within that there will be significant variations in the types of areas. CCG data is obviously much more granular. There are over 10 times as many CCGs as there are LCRNs, so it's much more granular. But of course, the location issue is much more significant with CCGs because we have to map where people are located to a CCG, and that probably means that CCGs close to large organisations such as teaching hospitals are likely to be seen as the recruitment location, even though patients may not live there. So it's much higher granularity with CCGs, but much more likely to be affected by bias. The analyses we did, three analyses for our questions. First, is recruitment aligned with disease prevalence in England? So we looked at this quite simply by charting the prevalence of disease in areas by the rate of recruitment, and I'll show you those graphs in due course. We also calculated a redistribution index, which is just an attempt to quantify how many recruits would need to be moved from particular areas to provide equal shares across these areas of England. We also obviously looked at whether alignment varies across clinical specialties, and is alignment getting better or worse over time, by taking those same analyses and looking at them within particular clinical conditions, and obviously looking at data over time that's collected by the CRN. So the first graph shows CCG level data. So CCGs have been grouped in terms of their prevalence into 5 groups. And as you can see on the x-axis, they are now put on that axis from lowest to highest prevalence of disease. On the y-axis, up the side, we have a recruitment rate per 1,000 people. And as you can see, there seems to be quite clear evidence of misalignment. The areas, the CCGs with the lowest levels of disease burden have the highest rates of recruitment, and as disease burden increases, recruitment rates decrease. The 43% represents an estimate of the degree of redistribution that would be needed to make the CCGs have equal shares of recruitment according to the prevalence of disease. Now, obviously, this is affected by the issue that we discussed earlier about bias, but that's an estimate of what redistribution would be required. The second graph shows the same, essentially, but with the LCRNs. Now, there are only 15 LCRNs, so we've put these on the x-axis individually. And again, this is the same graph. Broadly speaking, the patterns are similar. As you can see, there's a bit more nuance in this. But broadly speaking, areas with low prevalence have high recruitment rates, and as that goes across the graph into higher prevalence areas, the recruitment rate seems to come down. And again, the redistribution index for this is 12%, which suggests that 12% of recruits would have to be moved from high recruiting LCRN areas to low recruiting LCRN areas to make sure we had equal shares of recruitment according to prevalence. So they're the core findings. Moving now on to the findings about clinical disease. This table shows the same data in terms of recruitment shares by the three types of conditions, so all long-term conditions, diabetes and mental health. As you can see at LCRN level, 12% of recruits would need to be redistributed. Looking at all conditions, that's doubled to 24% in diabetes, but it's very similar in mental health. Looking at CCG level, again across all conditions, 43% across all, 53% in diabetes and in mental health. So this does suggest that although overall there's broad misalignment, this can be exacerbated in certain clinical conditions. So that's something we could look at in more detail as we move forward. The next table shows the same data but over time, so over 5 years of CRN data. So with all conditions, as you can see, the level of misalignment slowly increases over time. So the trend is slightly upwards, although the overall level of misalignment is relatively low. In diabetes, it starts off much higher, at 36%, and the trend is down over the 5 years, but still significant levels of misalignment in 17-18. And with mental health, again, it starts in the middle at 22%, and over time there seems to be some reduction. So the trend's down, but still significant misalignment in this important clinical area as we move forward. So limitations we need to consider. So not all research is on the CRM portfolio. So certain types of research don't go onto the portfolio, for example, routine data analysis. Certain studies don't go onto the portfolio for various reasons. And so this is not a complete and comprehensive assessment of all research, or indeed all NIHR research, but the assumption must be that quite a significant proportion of health research, applied health research studies go onto the portfolio. As I said earlier, patient recruitment location is recorded, not their actual place of residence. So there is this issue about the mapping of that data to where people are likely to live. And to really get to grips with this, we would need to start understanding where people live rather than where they're recruited. We've looked at a single measure of burden for simplicity in these exploratory analyses. Obviously, we can expand that to look at various other measures of burden that might be of relevance, but we felt CLORF had several advantages, including the fact that it's comprehensive, it's a well-regarded measure, and it does allow us to explore some of the issues that we're interested in about the effects on different clinical specialties. It's unique data as well. Now, this is advantages and disadvantages. It's unique because there's not many funders who are in a position to do this sort of analysis, but it does limit our ability to interpret the data because we don't know how this data stacks up against others, other research funders in a similar situation. So it does make it difficult to interpret, lacking any external reference for what we've done here. So what does this mean? The implications, how big is the problem? There is a significant problem. As I said, it's difficult to know how that compares to other research infrastructure. But if you look at the data from LCRNs, 10% of redistribution is still quite significant. So there is quite a significant problem with redistribution that we need to look at. So the initial suggestion from Chris Whitty and Louise Wood seems to be correct. Obviously, funders need to start encouraging research teams to think carefully about where they recruit, and there's various ways that this can be improved. The CRN has essentially created a targeting tool based on the data that you've seen today, which allows teams to identify areas where they're likely to find high levels of disease. And obviously there's research outside of this. The MRC and NIHR fund like trials methodology research, which looks at how you can best recruit people into studies. So we need to start drawing on that evidence base. The CRN has got its own project on best practice in recruitment on underrepresented groups, and they're also looking to enhance access to research, things like joint dimensional research, and be part of research, allowing patients more easily to access opportunities to take part. There is evidence that PPIE is related to effective recruitment, and the newest NIHR standards on this have highlighted the issue of inclusivity. So it's really important that our PPI endeavours take account of the fact that we need to find people who live in areas of high burden to enable us to use their insights. This data allows us to track change. As you can see, there is some suggestions that at least for some of these indices, things are getting better over time, and this data will allow us to track that. We also need to think about costs. Reaching out to new areas where infrastructure and attitudes to research may be different may have a cost in terms of research cost itself or the duration it takes to deliver studies, and we'll need to look into that to understand the implications. So thank you very much for listening. I hope that was of interest. We have a paper on this in BMC Medicine, and the link is there. We've also written a blog to discuss these issues in further detail, and do get in contact if you need any further information. Thank you very much.